Okay, let us begin with this morning session about atherosclerosis, cardiovascular disease, and the applications of nanotechnology. The first speaker is Professor Harald Mangge, Head of Research of the Research Unit on Lifestyle and Inflammation-Associated Risk Biomarkers from the Medical University of Graz. Welcome.
Hello, ladies and gentlemen. I'm happy to present you now some data and some discussion about the significance of immune-mediated inflammation for vulnerability in atherosclerotic plaque. You all know that vulnerability is a very important topic, and we have to catch the vulnerable plaques for early diagnosis and therapy. So our main goal of research in Graz and also within the NanoAthero project, this joint EU FP7 project where I'm happy to be part with, is to improve the prevention, diagnosis and therapy of fatal cardiovascular endpoints, most importantly myocardial infarction and last but not least strokes. So you all know atherosclerosis, it's a systemic disease with lipid deposits, a chronic inflammation involving T cells and macrophages, and it begins as early as in childhood, lasts very long. Symptoms are many years, even decades subclinically, and there is an urgent need for an improved early diagnosis and treatment. So I think we lose approximately 10 years for this early diagnosis, but there are many difficulties to catch the vulnerable lesions, and I want to discuss with you now in the following slides some aspects. So if we consider the vulnerable plaque, which is prone to rupture, it is characterized by a large lipid core with lipid peroxidation. There's a thin fibrous cap. There's excess of inflammation involving the T cells and monocytes. There's neovascularization. There is a disbalance, very important, between clotting and bleeding. There is activated endothelium, and there's less calcification. And so I start with the monocyte macrophages. The monocyte macrophages are really the principal offenders in the atherosclerotic process, and also so they play an important role for vulnerability. There are several subtypes, known phenotypes of these macrophages, with the most important one of the M1 and M2 subtype. The M1 macrophage produces pro-inflammatory cytokines like tumor necrosis factor alpha, IL-6, and the M2 macrophage more anti-inflammatory cytokines. And importantly, after lipid loading, both M1 and 2 generate foam cells which undergo apoptosis in later stages of the atherosclerotic process. But there is much difference between these M1 and M2 subtypes. Also, the bleeding process in the plaque scenario is important. Induced by free hemoglobin, the M2 subtype generates certain hemoglobin M macrophages with an decreased lipid uptake, a more non-foamy nature, and with increased cholesterol efflux. So this subtype is more protective. Very interesting, because usually bleeding is associated with vulnerabilization. And so it is very difficult to understand these Janus phases of the macrophages appearance. I told you about the M2, they are more the nice guys. The M1 is really the bad guy, with activated matrix metalloproteinases and so on, and the other ones remain to be fully understood. The M4 subtype, the M0 subtype, very difficult to understand. And to improve the understanding of this complex interaction between the macrophages, we have to go back to the immune system. We have to go back to the innate and adaptive immune response. I want to start with the adaptive immune response. there is activation of the immune system due to Th1 cells in the atherosclerotic plaque scenario. It plays an important role for vulnerability, but it's much more complex. You know that there are the regulatory T cells. They are interacting with the dendritic cells with more production of IL-10. There are some like an anti-inflammatory brake. And the antigen-loading dendritic cells are very important. And so we cannot understand the vulnerabilization of the plaque lesions if we do not learn more from the draining lymph nodes and the spleen and exterior amplification loops of the immune response. The microbiome may play an important role. You know, the gastrointestinal tract is full of immune system, and so there is activation which may play a role for this amplification loop, and there are also the infections. We know that myocardial infarction is occurring more frequently in spring or in autumn, and there may be more infections. Gamma interferon is important. It activates macrophages for increased productions of matrix metalloproteinase 9, decreased stem production, and this is important for vulnerabilization. We focus on matrix metalloproteinase 9 within the NanoAthero project. So there's a critical implication of the inflammatory response with T-cell complex, in a complex manner involved, but the Th1, the bad one, the Th17 cells, the T regulatory cells are more the stabilizing cell elements, and the Th2 is usually considered this substance as protective, but new reports show this is also not true. It can also act in some extent pro-atherogenic, and so this complex co-stimulatory and co-inhibitory pathway should be better in this understood in the future, and there may be come some help from lectures from the innate immune response. The innate immune response is also very importantly involved in the vulnerabilization process, and so especially the regulatory T cells and the dendritic cells, they play an important role. In the regions of non-uniform shear stress, where the dangerous process is active, the regulatory cells, if they are pre-incubated with dendritic cells, the dendritic cells show decreased adhesion and decreased chemotaxis. And so the regulatory cells have a very important role as brake. To improve the understanding and also to improve this complex network of the macrophage phenotype appearance, toll-like receptors may help. For instance, toll-like receptor 7 was shown to accelerate atherosclerosis in mice. If they are deficient, ApoE deficient mice also deficient for toll-like receptor 7, there is an increased size of the atherosclerotic lesions. They show more lipid deposits, more infiltration of macrophages, less smooth muscle cells, and less collagen fibers. These are all symptoms of vulnerable atherosclerotic lesions. And so, indeed, if toll-like receptor is less or more expressed in human carotid atherosclerotic lesions, this is very importantly associated with genes related to a more stable plaque phenotype. If there is increased expression of the toll-like receptor, you may find more M2 macrophage markers. If less expression, you will find the M1 macrophage markers. And very importantly, also thrombosis-related genes and stabilization-related genes are associated with toll-like receptor 7 expression. Even in active smokers, an increased toll-like receptor 7 expression may compensate atherosclerotic activity. And so we have really to improve the understanding of the toll-like receptors, also involve the toll-like receptor 2 and 4, to improve the understanding, to unravel the complex molecular machinery which leads to vulnerabilization of atherosclerotic lesions. So last but not least, also mast cells play a role. Mast cells are usually found around neovascularized areas in the plaque shoulder and the shoulder of atherosclerotic plaques, and there you can find also an increased tryptase content of mast cells, and this is associated with an increased risk of further cardiovascular events if you find this in the carotid plaques. Very interesting. So the interplaque hemorrhage, I also told you, is very important, maybe one of the most interesting phenomena, because you find here shown atherectomy specimen from a culprit lesion from a patient with unstable angina pectoris, and you can find this increased macrophage infiltration, but you find also increased expression of IL-10 and increased expression of iron. If the lesion is culprit, there is also an activity of the anti-inflammatory brake. This is very interesting for us also in the NanoAthero consortium, because we want to target IL-10 for an improved diagnosis and recognition of the vulnerable atherosclerotic lesion. And so the iron content and also other markers like the lipid pair oxidation are very important. Last but not least, to improve the vulnerable lesions, we have to decide between invasive methods and non-invasive assessment. The problem is how do we find asymptomatic individuals, whom and at which time? High resolution MRI may help, and molecular MRI may help, but the problem is, despite upregulated, the low expression of these targets like the adhesion molecules or the matrix metalloproteinases. A possible solution, and I come to the last slides, may be high payload contrast agents vehicles for a sufficient signal change. But the problems, the challenges we have to foster are we have to find a target ligand combination specific for the vulnerable lesion. We have to find a specific target with high expression level and favorable binding characteristics. On the other way around, the specific binding should be reversible, pharmacogenetics favorable, and should generate a robust contrast change. And last but not least, we have to find the right animal model for the development to the human pipeline. And this may be done, and we are busy with this in this NanoAthero project, where I'm very happy to be a part of it with 16 partners from 10 countries, where we have our main goal to demonstrate initial clinical feasibility of nanosystems for targeted imaging and treatment of advanced atherosclerotic disease in humans. We focus on stroke and myocardial infarction, and this is an exciting cooperation in this consortium. Thank you very much for your attention.
Thank you very, very much for this very nice presentation. Are there questions and comments from the public? Now I have a question. As you have shown, atherosclerosis is more complex than we thought 30 years ago. Now, with each research projects we add some challenges. What is the time horizon you believe that the approach of NanoAthero will have an impact on the practice of medicine?
Hopefully, I think that we will find in this complex scenario new target structures where we can catch the process more early. It's very difficult to differentiate in between the more stable lesion and the vulnerable plaque. So I hope there are so many different experts cooperating within NanoAthero, so we will find the right target, I hope, between immune activation and this dysbalance between clotting and bleeding in the plaque, and to combine this with the right nanovector for transporting contrast agents or possible also anti-inflammatory drugs. I hope that we will achieve a new tool to stabilize the process well before the clinical events occur. And for the time prospect, it's always difficult to answer, but I think it could be possible within the next 3 years.
Thank you very much. Yes?
Okay, so you made it a little bit more complex. So we knew about monocytes, macrophages, T cells. Now you added the subsets and the mast cells. Now in the end, if you want to translate back to humans, at some point in time you have to make an educated guess what the major cell will be to stabilize this. Now with all your knowledge here, can you bring us back to what cell would now be your primary focus with the highest chance of stabilizing these unstable lesions?
In my personal opinion, my stomach feeling, let's say, I'm convinced that the immune system is very important because it steers also this complex interaction between the macrophages. And so I hope if we can stabilize and down-regulate the immune activation in the right way, also the macrophages will behave in a more stable way. But it is really difficult to state this convincingly because it's really very complex, this interaction. But anti-inflammatory drugs influencing the immune activation in the right manner may be a good approach.
Thanks. Now let's move to the second